And the modified Lee symptom score, meaning the response with respect to chronic GVHD symptoms, was double as high in the RUX group as compared to the BAT arm. So here you see the best overall response that was also higher in the ruxolitinib group compared to the BAT arm. The duration of response was also higher in the RUX arm. Of course, it is important also to consider side effects, adverse events, and we observed that the adverse events overall were very similar in both groups. Grade 3 adverse events or higher were very similar in both groups. And when we look at the most frequent hematological adverse events, we found that there was more frequently anemia, grade 3 or higher in the RUX group with 12 versus 7.6%. Thrombocytopenia was not significantly different, but there was a trend towards higher. This makes sense because JAK2 is downstream of the erythropoietin and thrombopoietin receptor, and blocking that would lead to anemia and thrombocytopenia. Viral infections were not significantly different. Bacterial infections also not. There was a trend towards higher frequencies of fungal infections. So the conclusions here are that this is the first successful randomized phase 3 trial in adolescent and adult patients that have chronic graft-versus-host disease, which is not responding to corticosteroids. Ruxolitinib showed significantly higher overall response at week 24 compared to BAT, significantly improvement in failure-free survival, significantly greater symptom improvement with respect to the modified Lee symptom scale, and a higher best overall response rate up to week 24 compared to BAT. Importantly, the safety profile of RUX was also consistent with previous observations, and RUX is the first agent to demonstrate superior efficacy to BAT in a phase 3 trial in patients with chronic GVHD. So with that, I'm at the end of my presentation, and I will be happy to take questions. Thank you very much for your attention.
Thank you very much, dear Prof, for this informative and interesting presentation. And now we will open the door for a question. Okay, Dr. Khalifa.
Well, thank you for this presentation. Typically, these patients, once they enter into a nephrotic period, they are already on wide-spectrum antibiotic. So if the antibiotic solution, how can we explain? Because most of these patients, in spite of receiving broad-spectrum antibiotic, antifungal, antiviral, they still go into the graft versus.
Yes.
So, and if you want to introduce antibiotic later on, on what basis will you choose your antibiotic? Is it on biopsy, from intestinal biopsy, or what?
Yes, that is a good question. So I fully agree that patients who have symptoms for an infection, either fungal or bacterial, they need antibiotics. There's no question about that. Only patients that have no such signs and also no lab values that are indicative for any inflammation should not, at least in our center, are not receiving antibiotic prophylaxis. We give prophylaxis for herpes simplex and Pneumocystis carinii, but no antibiotics against bacteria as long as they are not having any symptoms. If a patient is neutropenic and has fever or has an increase of the CRP level, we immediately start with antibiotics. I fully agree with that. And also if a patient has graft-versus-host disease and has signs of infection, this patient definitely needs antibiotics. There's no question about that. It is just in the situation where we might not have any signs of infection, those patients should not immediately start it on antibiotics. That's our opinion, but you will find others, of course.
So if your patient has a white of 0, if they survive, how you would not give prophylactic antibiotic? How come?
If the patient has a low,
almost they go to zero count once they receive the conditioning regimen.
Yeah. So once he receives the conditioning and he has very low white blood cell count, if there's no sign of infection, we don't give antibiotics. We wait. But it's I mean, there is a controversy about that. There are others that are giving prophylaxis. We are not doing that, and we don't see more infections. We only react when there's an increase of the CRP or when there is a fever. Then we, of course, start with the antibiotics. But we don't give the antibiotics up front.
Thank you.
You're welcome.
Thank you for your excellent presentation. My question is on the differentiation between the skin involvement in GVHD and gastrointestinal. And I noticed that in the adverse events of the ruxolitinib, there was an increase in the rare. My question is, do you think that the mechanism of GVHD is the same in gastrointestinal and skin? And is ruxolitinib effective in both, as well as additional organ involvement, namely lung or neurons, neuronal system or other systems?
That is a very good question also. Yes, we performed an analysis for the different organs, and we studied response to ruxolitinib versus BAT in those different organs. And we found that in all organs, the response rate to ruxolitinib was better than BAT. This was independent of the organ. But the response rate of lungs were much lower than any other organ. The lungs are the worst. Chronic GVHD of the lungs is the worst to treat. I also agree with you that it is very likely that there is a different pathomechanism in intestinal GVHD versus skin graft-versus-host disease. In the acute setting, there are much more bacteria in the gut, of course, that can penetrate when you have intestinal GVHD, and intestinal GVHD is harder to treat and is more associated with non-relapse mortality. Skin GVHD, in most cases, responds very well, and therefore there are big differences. You also mentioned GVHD of the central nervous system. My group has studied central nervous host disease in mice and also in patients, and we found significant changes of the microglia. The microglia are antigen-presenting cells in the central nervous system, and we found them to be much more activated when patients or mice develop graft-versus-host disease.
I just want to inform all the audience that they could ask from their local sets. Until that time, I would like to ask you, Prof. You showed us an impressive finding through using ruxolitinib in the treatment of graft-versus-host disease. Did you try it as in the prophylactic regimen? So
we didn't try it in the prophylactic regimens, but there is a retrospective analysis by the group of Nikolaus Kröger from Hamburg. He treated patients with myeloproliferative diseases that underwent allogeneic transplantation with ruxolitinib. It was a single-arm study, and he found that these patients had very low levels of graft-versus-host disease. There was never a randomized study on this question, but at least not a published one. But there are trials ongoing with selective JAK1 inhibitors for the prophylaxis of acute graft-versus-host disease. And we will see what comes out. It's certainly an interesting thing, and it would be much better to avoid GVHD rather than treating it. And as well, you do know that we may continue using in chronic graft-versus-host disease anti-graft horse for more than 6 months, maybe reaching 2 years or above. For how long you could last using ruxolitinib? So some patients are receiving ruxolitinib for a couple of years, even. So I have one patient who has it now for 2.5 years. And always when I try to taper the last 5 milligrams, the skin is starting to itch a little bit again, and I have to put it back. But he has no side effects. So a low dose ruxolitinib can be given for very long. the dosage that we are using is quite low. I mean, it's 50% of the dosage that is approved for myeloproliferative diseases. Their patients receive 2 times 20 milligrams, and we are giving 2 times 10 milligrams only. So it's a low dose treatment, but it's can be given for a pretty long time.
Okay, I will go to the monitor to look if there is. Please, Dr. Khalifi, the mic is yours.
What about the role of plasmapheresis in the patient get into the chronic?
So there have been studies with plasmapheresis for chronic GVHD because it's an B-cell mediated disease, and antibodies in the plasma could be eliminated, but they were not very successful. And so all the literature that I know shows that it's not a very successful intervention, plasmapheresis for chronic GVHD. But for example, extracorporeal photophoresis, ECP, is a very successful therapy for chronic GVHD. But the response rates were around 38% in the REACH-3 trial versus 49% for ruxolitinib. So ruxolitinib was more effective than ECP.
Thank you.
Please, I will go to the monitor to check if anyone of the audience want to ask. I don't know if you have the question.
Has somebody asking for?
We have a little time. We would like to see if there's anyone from the audience want to ask. We still have a time. Please check. Is there a shaking hand?
There is somebody called Khalid Halamek.
Okay, please.
But I can see it only in the chat. He's asking, but he cannot speak because he's muted.
Please unmute him. I will ask the monitor to unmute him.
Are you hearing me?
Yes.
Yes, thank you very much. Thank you very much for this comprehensive. I was a little bit late. I didn't connect, to be honest. But I have patients. We were part of the trial of that REACH-3 trial. We have 2 patients included. And I have 1 patient on off-label use. I'm using the 2 milligram BID. He is post-allogeneic bone marrow transplant for his relapsed acute myeloid leukemia. And he has skin and subcutaneous GVHD. I mean, with the eyes and mouth. He's like have a moderate chronic GVHD by NH criteria. So my question, even at morning, we were discussing in the morning meeting, we were discussing the Roxo part, and I asked a question: what is the best? How is the sequencing of tapering off immunosuppression? As you know, when your patient getting to Roxo, he's a steroid refractory, probably he's a CNI, and he is on mycophenolate. And my patient in particular, he completed ECP, even the full protocol for a chronic GVHD. So what's the best sequence you would taper off these immunosuppression? And I know probably you would keep the Roxo at last. And as mentioned by Dr. Majdi, those patients requiring like a year or so of therapy and even more than that. So my question, how would you taper off all of these immunosuppression? Would you taper off CellCept, for example, from the start? Would you start by CNI and keep Jakavi? Can you comment on that, please? Thank you.
Of course, yes. So our procedure is that we first taper the corticosteroids. If the patient has still corticosteroids, because our experience is that they are the most toxic, have the most side effects. And then we taper the calcineurin inhibitor. So I think we never had a patient who had calcineurin inhibitor and MMF for chronic GVHD.